Hello, today we are going to talk about the most common diagnosis when your provider, your doctor, tell you that you have Parkinsonism, but you do not have Parkinson's disease, and your Parkinsonism is not due to medications. I'm talking about PSP, Progressive Supranuclear Palsy. If you want to go directly to the PSP information, just click in the PSP section in the description of this video. Let me start by defining what do I mean with Parkinsonism. It is very common to see people getting confused about Parkinsonism, and Parkinson disease. In the same way that people get confused about Alzheimer and dementia. So dementia and Parkinsonism are big terms. And after that, there are many causes that cause dementia and cause Parkinsonism. So they are not the same. When I say Parkinsonism, I mean slow movement and either tremor, resting tremor, or stiffness. That's the definition of Parkinsonism. You have a slow movement, you move slow, but also you have either or both resting tremor or stiffness. Now, there are many causes of Parkinsonism. The most common cause is Parkinson's disease by far, approximately 70% of the time. When you have Parkinsonism, the diagnosis is Parkinson's disease. Now, what about the rest, the 30%, the 25% of the time? Well, so there are many other causes. So let's talk about this one first, which is a very rare form of Parkinsonism, very rare. And it's what we call functional or psychogenic. And I say psychogenic because this is a controversial term. We like to use the word functional, even though that functional creates too much confusion as well. Functional Parkinsonism. So it is when your brain is not connecting well, which in the brain by itself is not connecting well. So it's like having a software issue, but your hardware of your computer is working well. It's a miscommunication between neurons. So that's one cause. The other cause are what we call secondary causes. So primary causes means Parkinson's disease and this group here that we are going to talk about soon. But secondary causes are due, for example, to medication that block dopamine, and I will show you which medication I'm talking about, but also vascular insults. For example, having a stroke, an infarct, affecting specific area of the brain that might cause Parkinsonism, even though that the term vascular Parkinsonism is a very controversial term, because not every patient, when you hit those areas, they will have Parkinsonism. Some of them. Why? We don't know. Other causes of secondary Parkinsonism are toxin. And you ask me, which toxin are you talking about? So, for example, manganese. If you take a lot of manganese for whatever reason, you might have Parkinsonism, and it's due to excessive intake of manganese. Other reason, other toxin is when you have carbon monoxide intoxication. Carbon monoxide intoxication. That's another reason. And there are many other toxins that might cause Parkinsonism, but these are the most common one. Now, when we say that you have primary Parkinsonism, and I'm talking about where the problem is directly caused by the disease in the brain by itself and not due to medications like the dopamine antagonist that we're going to talk about that soon, then you say that the patient has primary Parkinsonism, either Parkinson's disease or one of these diseases that we have here. So for example, multiple system atrophy, progressive supranuclear palsy, which is the most common cause of primary Parkinsonism after Parkinson's disease. Okay, and so this is how I started this lecture. So what is the most common cause of primary Parkinsonism when you don't have Parkinson's disease? So this is PSP. But also you have other conditions such as cortico-basal degeneration, dementia with Lewy body, spinocerebellar ataxia, and even frontotemporal dementia. These are the list of medications that might cause Parkinsonism. The majority of these medications block dopamine. So when you have a patient who is taking dopamine antagonists or medication that block dopamine in high doses, and many times even with low doses, you will look like a patient with Parkinson's disease. But usually you don't have Parkinson's disease. The only way to differentiate this is number one, or you stop the medication and wait months, which many times, frequently, you cannot do that. Or proceeding with a DAT scan, DAT scan. DAT scan, DAT scan, easily differentiate between drug-induced Parkinsonism and primary Parkinsonism, such as Parkinson's disease. Because in primary Parkinsonism, such as Parkinson's disease, would be abnormal. The DAT scan would be abnormal. In medication-induced Parkinsonism, will be normal. Okay? Now, these are the list of medication, but there are many others, but this is the most commonly used. So if you are taking one of those medications and the doctor tells you that you have Parkinson's disease, double check, okay? Because there's no way to differentiate. In your case, if you are taking one of those medication, you need to get a DAT scan in order to differentiate. And then if you ask me which anti-dopaminergic agent, or another term that we use, antipsychotic medication, or sometimes we call neuroleptic medication, which one are less likely to cause Parkinsonism, lower risk, are this one that you see here with the lower risk. Okay. And if you ask why I didn't mention clozapine and Seroquel or quetiapine, because they are less likely to cause Parkinsonism. So they are very, very safe from the movement disorder standpoint, even though that at very, very, very high doses of those medications, even Seroquel might cause Parkinsonism too. But it's very unlikely, and you need to go very high in order to cause Parkinsonism. Now let's talk about why this is important. Why I'm talking about this. Why it's so important to differentiate between this type of Parkinsonism? Well, I will tell you two main reasons. Number one, because the prognosis is different. By far, I would prefer to have Parkinson's disease by far than having PSP or any other of the atypical Parkinsonism, by far, because it's very important for realistic expectation and plans for the future. And I will talk about prognosis later, but this is very important to know what you have, or at least having an idea. Because remember, there is no way to be 100% sure. The only provider that can make diagnosis 100% sure is the pathologist. And this is when you get autopsy. Okay. Now, reason number two, and this is very important, is if we want to find a cure for these diseases, we need to have the correct diagnosis. Otherwise, you will go to the incorrect clinical trial. So that's why it's so important to be sure, or at least having a good sense specificity in the criteria that we are using to make the diagnosis correctly so patients can go to the correct clinical trials. In that way, we will be more close to get a cure for these diseases. Now, when do you start thinking about this atypical Parkinsonism? When you find something that doesn't fit well with the diagnosis of Parkinson's disease. We call that red flags. So when you see a red flag, that means that this is a atypical feature, a typical characteristic. And I will go one by one. When you see one of these atypical features or red flags, you need to start thinking about other conditions that are not Parkinson's disease. They look like Parkinson's disease, but they are not. What are those red flags I'm talking about? So I will talk one by one. There are 10 red flags. So if you see one, if you have or your loved one have one of these red flags, or especially there are multiple of them, you need to look for another diagnosis because maybe you do not have Parkinson's disease. Okay? So these are red flags. Remember, red flags means that you need to start thinking about something else. Start thinking about something else. That doesn't mean that you do not have Parkinson's disease, okay? Number one, rapid gait walking. Gait means walking problems, progression. So which means that if you have somebody who is using the wheelchair or basically wheelchair bound during the first 5 years of the disease onset, you need to start thinking about something else because this is not Parkinson's disease. Most likely is not Parkinson's disease. Okay. Number two, lack of progression. So you have somebody who you see them every year. And by the way, the diagnosis of Parkinson's disease need to be reevaluated every year because things might change. But imagine that you see this patient and every year, and the patient is actually every time that he show up or she show up, she or he is better. So that doesn't fit well with the neurodegenerative disease. So you need to start thinking about why this is happening. Well, it's possible. You still can have Parkinson's disease, and every time that you show up during the next 5 years, you are even better. For example, if you see a video of Jimmy Choi, you can tell that every time that you see a video, he's even better. Why? That is different because in his case, he's doing high intensity exercises to the extreme. So those patients, they will look better. They will really look better. So when you do high intensity exercises, you will keep looking better. Obviously, there is a limit, right? It's like age. So there's no way I can compare what I was able to do physically 20 years ago than now. So age is an issue, right? But if you have a patient who you don't see that they don't get worse, not like this, actually better, you need to start thinking. Okay, it might be because of, like I say, high intensity exercises or actually responding to medication very well. I have seen that. Okay. Now, number three, when you have what we see here, early bulbar dysfunction. What is that? So bulbar means the distal part, the back of the head. There is something that we call the brainstem. So it's the last part of the brainstem. Then we call that the medulla oblongata. So when you have patients having that area of the brain affected, which they will present with swallowing issues and speech issues, very severe during the first 5 years, you need to start thinking about something else. Okay. For example, when you cannot understand, I'm talking about severe cases, when you cannot understand what the patient is telling you during the first 5 years, or the patient need to modify the way that they eat, otherwise it will cause an aspiration pneumonia. or the patient require a peg tooth, or some type of modification in the diet during the first 5 years, that's a big red flag, okay? Most likely they might have something else like PSP or multiple system atrophy. Now, this is another one. Number 4, respiratory dysfunction, and specifically these two things here. So for example, if you love one, because the patient would be sleeping, usually they will be sleeping and making this noise. This type of noise. This is an inspiratory stridors, okay? Let me show you this video. This patient with the diagnosis, the clinical diagnosis of MSA, multiple system atrophy. You will see, just pay attention to the jerks and the breathing. Just listen to the breathing. That's the breathing I'm talking about. And pay attention to the jerks right there. There are many features here suggesting MSA. Red flag number 5. When you have severe, what we call in medical terms, autonomic failure or autonomic dysfunction. So the autonomic system is the system that controls your internal organs, such as the blood pressure, the heart rate. And this is the one that is related with constipation, bladder issues, and all these things inside of your body, right? So here we are talking about when you stand up and the blood pressure drop. Severe. So we call that severe orthostatic hypotension. If you see that, when you stand up and after 1 minute, 2 minutes, so within three minutes, your blood pressure drop more than 30/15, that's a big red flag. You still can see that in patients with Parkinson, but again, that's a red flag and you start thinking about something else. In this case, we are talking about mostly multiple system atrophy or even dementia with Lewy bodies. You can see that. Also, urinary retention, so which means that you cannot pee. That's not a Parkinson feature, unless you can explain that with something else, like a prostate, right? If you have a big prostate and you have a obstruction, that's different. But typically, you don't see urinary retention in people with Parkinson's disease. So that's another red flags. The other thing is incontinence. However, you can have stress incontinence, which means that you have the desire to go to the bathroom, but the intensity of the contraction of the muscle in the bladder is too high, too intense that you pee on yourself before getting to the toilet. So that's another red flag. When you have incontinence not related with stress incontinence, which is you can see that in people with Parkinson. Now, frequent falls. I'm talking about during the first 3 years. When you have somebody falling down frequently, more than one fall during the first 3 years, that you don't see that frequently. You don't see that with Parkinson's disease. And when you see that with atypical Parkinsonism, such as multiple system atrophy and PSP. Now, number 7 is hands contractures or deformity of the hands and anterocolis. Anterocolis means that colis means neck, anterior, so which means that your neck is excessively flexed, especially during the first 10 years. That's another red flag. Now, when you have somebody with 5 years of symptoms onset, motor symptoms onset, for example, a resting tremor and a mild slow movement. So you have the diagnosis of tremor, or you have the diagnosis of Parkinson's disease. But after 5 years with the disease, there is no history suggesting non-motor features such as depression or bladder issues or REM sleep behavior disorder or any of the autonomic symptoms, then you start thinking about something else, okay? When you have weakness, and let me clarify this, because there are many patients with Parkinson that they tell you, I feel weak, but when you test them, they are actually not weak. They're very strong. Is they are slow, but that's the way that they explain. Because when you test them with the manual muscle testing, they can break your hands. But they feel weak, and most likely they feel fatigued, tired. So you have to be careful when the patient is telling you that they feel weak, because they are actually not weak. But when you see focal weakness, real weakness, and especially with high reflexes, we call that hyperreflexia, that's not characteristic for Parkinson's disease. You need to look for something else. Unless the patient can still have Parkinson's disease, but maybe they have a stroke, right? On the top of the Parkinson's disease. So still, remember, all these characteristic features, that doesn't rule out Parkinson's disease. I will tell you later what rule out Parkinson's disease. But these ones, the red flags, that doesn't rule out Parkinson's disease. But when you have many of them, you start thinking about something else. And the last one is when you have bilateral and the same type of severity in both sides. So the right side and the left side are the same. So that's not typical for Parkinson's disease. Parkinson's disease attack more one side than the other. And not necessarily will be the right side or the left side. It doesn't matter. Okay? It doesn't matter. There's one feature, one characteristic that is not included in this clinical diagnostic criteria published in 2015, which is dementia. I personally believe when you have a patient who start having Parkinsonism and also significant, severe cognitive issues affecting function, daily activity, we call that dementia, I cannot make the diagnosis of just Parkinson's disease. This patient probably have atypical Parkinsonism, either dementia with Lewy body or PSP. So that's the only thing that I disagree with the clinical diagnosis criteria. It's just that they remove the word dementia, the term dementia from the criteria. And many people disagree with that, but that's the only thing. Now to finalize and then start talking about PSP, let's talk about what features, what characteristic rule out Parkinson's disease. So if you have any of these features that you see in the screen, any of them, the first eight, and I'm going to talk about the number 9, but the first eight, if you have one of these 8 features, you do not have Parkinson's disease based on this criteria. Okay. Number 9 is basically an expert opinion, so I'm not going to talk about that. Number 1, if you have cerebellar dysfunction, what is that? So the cerebellum is the back of the head. We call that the small brain. Some people call it small brain because it's smaller than the actual brain. And the function is the coordination, and including the coordination of the movement of your tongue. So that's why when you say that cerebellar speech, so those patients with cerebellar speech, they will talk like being drunk. Because remember, alcohol affects the cerebellum acutely and chronically. And that's why this is the best description of explaining you that a patient with cerebellar speech, we call that scanning speech, is like being drunk. But also affect the eye movement. You might have nystagmus, which is the eyes move like this, jumping. And also you have incoordination. So when you tell the patient to walk in a straight line, they will have issues, significant issues. Or finger to nose, they will have issues. They will have incoordination. Now, number 2 is, this is very important, because if you see that, well, if you see any of those factors, basically rule out Parkinson's disease, but this is a very important, at least for me. When you see that the eye movements are affected when the patient look specifically down or slow or any type of restriction, initially it could be only slow. This is not Parkinson's disease, is most likely PSP. Okay, so I'm not talking about upward, because upward, when you get older, you might have some limitations. So you see when you test eye movement and you tell the patient to follow your fingers, okay, pursuits, we call that pursuit, there's some restriction. When you test that in a 90 years old lady or guy, you can see that. So I'm not talking about that. It's restriction or slowness looking down, specifically down. That suggests that you have PSP, although you can see in other conditions as well, but not with Parkinson's disease. Okay, I'm talking about things that rule out Parkinson's disease. Number three, and this is pretty obvious, that if you have features, characteristics suggesting frontotemporal dementia, or what we call primary progressive aphasia, which is a problem with your language severe enough to have the diagnosis of primary progressive aphasia. So that's a pretty easy one. I don't know why this one is here. Number four, if you have Parkinsonism, remember what I say, what is Parkinsonism? Parkinsonism means slow movement and stiffness, right? Only located in the lower extremities for more than 3 years and just lower extremities. You need to start thinking, this is not Parkinson's disease. This is probably something else, such as what we call vascular Parkinsonism. There are some patients that they have significant white matter disease, subcortical. So the cortex is the external part of the brain. So it's sup of the cortex, a lot of white matter disease. So which means that the patient might actually present with lower limbs, legs, Parkinsonism. Another condition that might present like that is what we call NPH. NPH, normal pressure hydrocephalus, which is a kind of controversial topic. But you can see that there are some rarely you can see patients with pure NPH and they present with lower limb Parkinsonism. Okay. Number five, when you have a patient taking a medication that block dopamine, specifically D2, there are many dopamine receptors. So I'm talking about D2. So all those medications I showed you before, any of those medications might cause Parkinsonism. And when you have a patient taking those medications, you cannot make the diagnosis of Parkinson's disease. Why? Because those medications can cause Parkinsonism, and there is no way that you can differentiate clinically between a patient with drug-induced Parkinsonism and idiopathic or Parkinson's disease, what we call Parkinson's disease. There's no way. The only way is, like I say, doing a DAT scan or tapering down those medication and wait months and even 18 months. There's some paper, one paper describing that patients actually recover completely after 18 months. So in those cases, if you are taking one of those medications, as I mentioned before, you need a DAT scan. Easy to make the diagnosis because the DAT scan will be abnormal in patient with Parkinson's disease and normal in patient with drug-induced, medication-induced Parkinsonism. Number six, when you give a patient significant amount of levodopa, and I say levodopa because levodopa is the best medication we have available, the most potent. And you are giving the patient more than 600 milligrams per day of levodopa and doesn't do anything for the patient. So I'm assuming that the patient has at least moderate severity of the disease, okay? Because remember, I have a video describing 5 reasons why the patients tell me, or tell the provider that the medication, the levodopa, is not doing anything for them. And one of the reasons is because the severity of the disease is very mild, so you don't have enough room to improve, right? So very important that when you, before saying that the medication, the levodopa, is not doing anything for you, you need to take good doses, at least 600 milligrams daily, at least 600 milligrams daily. Now, another thing is, number 7 is if you have what we call cortical symptoms. So, for example, if you have if you put things in the hands of the patients and the patient cannot identify what you are putting, that's not Parkinson. That's something else. The same thing if you write something in the palm of the patient and the patient cannot tell you if you are writing number 1 or number 8, that's not Parkinson. Unless a patient can have Parkinson, but you need to explain that. So for example, maybe patient has a stroke in the parietal lobe. So and that's why the patient cannot detect, they cannot identify what you are writing in the opposite side. So it's just you need to correlate with everything. You need to put things together here, okay? Number 8, if you have a normal DAS scan, as you see here, that technically rule out Parkinson's disease. However, you need to make sure that the person who is reading the DAS scan is a radiologist, fellowship trained in nuclear medicine. Okay, remember what I told you about the complexity of medicine. So the same thing apply with radiology. So there are extra training in those radiologists. So be careful. And number 9, I'm not going to talk about number 9 because it's an expert opinion. Finally, let's talk about PSP. What is PSP? Remember, PSP stands for Progressive Supranuclear Palsy. And you will see that, Progressive Supranuclear Palsy. Progressive means that there's nothing that we can do to stop the progression. Okay, it's a progressive disease. If you don't progress, then you don't have a neurodegenerative disease, especially PSP, that progress significantly faster than a patient with Parkinson's disease by far. Then what is supranuclear palsy? Which means that the pathology is about the deep nucleus that control the eye movement, which is located in the back of the head. We call that the brain stem. So it's the pathology, the problem is over that, is about that. Remember that the eye movement abnormalities are the main characteristic of PSP. However, there are many PSP subtype that initially the eye movements are normal. So, and this is when things get more complicated. Now let's talk about risk factors. So what put you at risk? Well, the first thing I have to tell you is age is the only one that we are sure that when you get older, the chances of you having this disease increase significantly. People usually start having this disease at age 60 something, 64, 66. So age is the main thing. And actually, let me tell you that there is no case report of any patient pathologically diagnosed officially by the pathologist during autopsy with this disorder before age 40. Okay, all the patients reported, all of them older than 40 years old. Now, this disease is not classified as a genetic disease. It's sporadic. We call that sporadic. However, if you have family history, first degree relative, which means your brother, your sister, your mom, your dad has the disease and you get the disease, or a disease like ALS or frontotemporal dementia, there is one gene that you should check. Only one gene. And it's this one here, C9ORF72 gene. This gene is highly associated with PSP and frontotemporal dementia and also ALS. So if you have a first degree relative with these disorders, you should get this gene. The problem is that Medicare doesn't cover for that. But that's the only way, the only chance to know what you really have. So it's getting this genetic test. Now let's talk about what are the symptoms. When to suspect. When do you suspect that you or your loved one is having PSP? The first thing I have to tell you is that there is no not every patient is the same. So every patient is totally different. There's significant variability, different flavors, different subtypes, even more than in Parkinson's disease to make things more complex. But there are mostly four core symptoms or characteristic. Number one, which is the most important one, why? Because all the patients at some point, even initially or at late stage, will have eye movements abnormalities. When I say eye movement abnormalities, I mean that they cannot look down or significant restriction looking down, specifically down. Initially could be just very subtle, very mild, just slow, horizontal, vertical gaze, slowness of the movement. Initially could be like that. Or initially could be just a little bit of jerky movement of the eyes, both eyes. Very, very difficult to detect, especially if your eyes are not trained to detect that. So that's why if you are seeing a neurologist and you have Parkinson and the neurologist is not checking your eyes, change the neurology, okay? Change. Look for a second opinion because eye exam in movement disorder is extremely important. Why? Because the diagnosis of Parkinson's disease might change. That's why I'm telling you that every year we need to reevaluate the diagnosis of Parkinson's disease because things might change, especially during the first 5 years. After 5 years, most likely this is what you have is Parkinson's disease. But during the first year, it's like flipping a coin. Now, going back to the course symptoms. Number one is vertical eye movement abnormalities. And let me show you a video now so you can see what I'm talking about.
Look at me here.
So let's see this video together.
Look my
So you
finger
can see
here.
that the patient cannot look up. We call that vertical gaze palsy, but also he cannot look down, which is more important. They cannot look down.
Now look my nose here, okay?
And
Look my nose.
this problem is overcome by activation of the vestibular ocular reflex, which is the doll's eyes. So the patient can
Good, perfect.
overcome with this maneuver. And look how this patient stand up, very classic type of walking. It's a wide base support. The arms are a little bit away from their body.
Walk a little bit.
And you can see this is a typical gait of a patient with
Perfect. Go back to your
PSP,
chair.
Richardson syndrome, that we are going to discuss soon.
Perfect.
Now let's talk about the second symptom, the second characteristic, very important, which is postural instability, which means that when I pull the patient from behind, the patient fall or at least step backward more than twice, more than 2 steps. That's abnormal. And this is what we call postural instability. So this is a very common reason for patients with this problem to fall. So if you ask me how common is falling down if you have PSP, actually we have a study published in 2006, and I will show you this in the graphic. In this graphic, showing that patients with PSP start falling down during the first 2 years, and specifically based on this study, month 16.8 months. So basically before 2 years, compare with patients with Parkinson's disease that they start falling down after 9 years of symptoms. You see here 108. Symptom number 3 is Parkinsonism. But this Parkinsonism in these patients is atypical. Atypical means that they don't have the typical decrement that you see in people with Parkinson's disease. The amplitude is slow of the movement, but sometimes they have it, but frequently, they don't have the typical decrement that you see in people with Parkinson. And the stiffness is very, very pronounced at the level of the neck. Also, the symptoms are in both sides similarly. Different from patients with Parkinson disease, they have one side more affected than the other one. In PSP, typically is both sides. However, there is exception to the rule, and there is a subtype of PSP, which is very asymmetric. Actually two subtypes. One of them we call PSP Parkinsonism, and the other one is PSP corticobasal syndrome. I'm going to talk about that soon. So that's why this is very complex sometimes to make the diagnosis, because features, symptoms overlap. Number 4, and you will see here, is cognitive deficit. Initially, some patients, they do not have criteria for dementia. The symptoms are very mild. And then after a few years, you can start noticing, at least very clear, the degree of dementia. Now let's talk about the subtypes that we have. When I say subtypes, are basically the flavors. So we have different subtypes. Medical terms we call also subtypes as phenotypes. We have more than in Parkinson's disease to make things even more complex. So these 4 that you see here are the most common one. The first one is the classic PSP or Richardson syndrome, because Richardson is the last name of the physician, the doctor who talked about this, who described this syndrome many years ago, I believe in 1963. So those patients are very easy to diagnose, very easy to diagnose. Although, at least for a movement disorder doctor, it's very easy to diagnose. The other ones are more complex, but this one is very straightforward. Those patients present from the beginning with frequent falls and severe balance issues from the beginning. So remember what the graphic I show you about the difference of falls when patient with Parkinson's disease start having falls and when patient typically with PSP start having falls. There is a difference. So these patients with classic PSP start falling down from the beginning during the first 2 years. Now, they also have, and this is very easy to identify when present, vertical gaze palsy. I will show you videos about that again. And especially looking down. And that's why many family members tell you that the patient is a messy eater, because they cannot look down. So it's so messy. When they eat, it's a mess. They also have Parkinsonism, right? But it's different. This Parkinsonism is atypical, affect more the trunk, the neck. So a lot of stiffness, rigidity of the neck. And they have this characteristic voice. It's kind of robotic voice. When you see so many patients with Parkinsonism, you can identify many times this based on the sounds of the voice without seeing the patient, just the sound. If this patient sounds as a PSP or MSA or the voice of Parkinson. So it's very interesting. Only people who see patient with Parkinson and PSP can tell you that. And also the family members, obviously, family member that they live with the patient, this person sounds like my dad. So they can tell you that. Also, this patient with classic PSP, they have cognitive issues from the beginning. Some of them not severe enough to call it dementia, but after a few years, all of them will have dementia. And one characteristic feature, very interesting, is when they come to your clinic, many of them, they come with sunglasses. So there are two things in neurology that when you see somebody in your clinic with sunglasses, inside of the patient room, or the patient have migraine or PSP. Okay, think about these two problems. Another characteristic is like these patients don't respond to levodopa in the same way that in Parkinson's disease. They might respond initially mildly, but they don't sustain the benefits. So they might respond, they might tell you, I'm not sure, and they might actually respond, but you need to push the doses higher, okay, in order to say that the patient is not responding. I will talk about treatment in another video. But one of the things that we do in patients with PSP is to push the doses higher, just in case, okay? Just in case, because some patients respond, approximately 20 to 30% of the patients respond to levodopa, which is the most potent dopaminergic agent that we have available. Number two, and this is the second most common after Richardson syndrome, the classic PSP. So I'm talking about number two, which is PSP Parkinsonism. This is difficult to differentiate from Parkinson's disease because this one actually mimic Parkinson's disease, even with the tremors, even with the asymmetric presentation. And actually, they even respond to levodopa, but decline after 5 years or so. So you see after 5 years or so, I put here 5 years, but could be 4, could be 6, could be even 10 years. So the prognosis of this one is actually significantly better than the other ones. So those patients, and I will talk about prognosis later, but the prognosis of these subtypes is significantly better than this one by far, by far. So this patient over time will have all of them. Remember, all of these subtypes, they will evolve to this one at some point. It might take 15 years, it might take 10 years, it might take 7 years. Everything depends, right? So then you might ask, so these patients, when you have this problem that you are thinking about, if this is the classic Parkinson disease or we are missing something here. So you might say, maybe it could be PSP-P, the differential diagnosis, because the patient is having more cognitive issues than usually that you see in people with Parkinson. And then you might think, let's do a skin biopsy, because a skin biopsy would be positive. I'm talking about scene one test. I have a video about when we can perform, when we can order skin biopsy. But you can think, well, if this patient have some overlapping feature, or you are not completely sure and you want more data, then skin biopsy would be appropriate in these type of cases. Because skin biopsy, when it's positive in the correct clinical setting, in the correct patient, is very helpful. Because when it's positive, it's positive. Now, when it's negative, you just crush your head. And you start thinking, well, this could be a false negative test. Because not all the tests are perfect. You can be a false positive test. Although the company claim a very high sensitivity. But it's hard for me to believe that, but this is what they say. So, and actually, let me give you an example. I have a patient with 2 years history of resting tremor, responding to levodopa pretty well, and actually some even wearing off, which is characteristic for Parkinson. You were wearing off, so responding. Now that doesn't confirm the diagnosis of Parkinson's disease, but it's a very classic characteristic, including the tremor. It's very classic, the resting tremor, 4 frequency, 4 hertz in terms of frequency, very classic. And but the family, especially son, can identify that something is not right in the way that the patient is thinking. Some cognitive impairment, but not to the point that call it dementia. You can see that with Parkinson's disease, but there is a concern. So we decided to do the skin biopsy, which I typically would not do in this type of patient. I just follow up them and we'll see. Um, and the biopsy turned out to be normal. And then what? Well, still my diagnosis because I do not see any red flags. There's no red flags in this case. And there's no exclusion, absolute exclusion criteria. Still my diagnosis is tremor, predominant Parkinson disease. Skin biopsy, negative. We'll see. Okay, we'll see. Obviously, this patient needs a close monitor, and because things might change. Because remember what I told you that if this is PSP Parkinsonism, you will see some changes later. Especially if we are talking a guy who started having symptoms 2 or 3 years ago. Let's wait during the next. Let's see what happened during the next 2 years, right? So that's about PSP-P, which is the second most common one. This one, the PSP oculomotor dysfunction, I haven't seen that. And probably because those patients go directly to the ophthalmologist. And if you have an ophthalmologist or any eye doctor who is not familiarized with this condition, oof, you are not going to have the diagnosis. And you will have the diagnosis when you see a neurologist, specifically a movement disorder. So that's why I don't see this presentation. But remember, those patients start with this only a minimal or no balance issues, and later on they develop the motor symptom, the Parkinson symptoms, and the eye movement abnormalities. Well, eye movement abnormalities, they start with that. Then this one that we have here is the PSP with gait freezing or walking freezing. So I have seen this. So this is a type of patient that they freeze. It's like having glue. They try to initiate the walking, the gait, and they cannot move the legs. And there is significant stiffness in the lower limbs. But mostly they cannot move the legs. It's like having glue on their feet. And this might actually lead to falls. Now, these are the less common subtypes, and the PSP with frontal presentation. This is very difficult to diagnose because there's an overlapping with frontotemporal dementia, very similar to frontotemporal dementia. And remember what I told you, that there is a gene that is associated with frontotemporal dementia, PSP, and ALS presentation. So to make things more complex, many times these presentation overlap. So these patients, they present initially with behavioral changes, behavioral issues, similar to, or actually very almost the same, a frontotemporal dementia. And then they have the eye movement abnormalities and other features characteristic for PSP, and that's why we call it PSP with frontal presentation. They present like this, and they end up having the typical Richardson subtype, classic subtype PSP. This is another one that they present has a speech language issues. Language, they cannot express themselves. They present with a lot of language issues, and then they end up having the classic PSP. This one, I have one patient only, one patient. And this is I will show you a video soon about this patient. This is a patient present with corticobasal syndrome. Okay, I'm not saying degeneration. Degeneration is the disease. This is the syndrome. You can see that with other diseases, including Alzheimer and PSP. So those patients, when they have very asymmetric presentation. So one side very affected compared with the other one. The hands, we call that something that we call alien hand syndrome. They lift the hand, they don't have control. They do things with the hand, one hand, and it's like the hand is on their own. They have significant abnormal posturing, and they have even jerks. So all these are cortical symptoms. The cortex is the external part of the brain. Now, there is something that we call PSP cerebral ataxia, which is incoordination. I have not seen that. And so those patients present with cerebellar symptoms, and they end up later having the classic PSP, the Richardson syndrome at the late. And then you have the PSP with primary lateral sclerosis, which typically you see those patients initially in the neuromuscular clinic, and then they start having characteristics suggesting of PSP, and that's why they have this diagnosis. So he came with sunglasses, and just to summarize, he started having walking issues, balance issues, approximately 2 or 3 years ago, right?
Yeah.
Yeah, more or less. Okay. Then look the camera, okay? Look the camera. And then follow my finger with your eyes. Don't move your head. Look up. Look down. Don't move your head, your eyes only. Look up. Look down. Okay. Now let's talk about how to make the diagnosis. So when I say we, I mean movement disorder specialists follow the clinical diagnosis criteria by the Movement Disorder Society. This paper that you see here, published in 2017. The only thing I will tell you is if you or your loved one suspect that you have PSP, it's better to see a movement disorder specialist. Why? Because this disease is very, very complex and can mimic many diseases, especially the subtypes outside of the classic PSP or what we call Richardson syndrome. The Richardson syndrome is very straightforward, but the other ones, not at all. And they overlap with many other things. That's why it's so important that you look for expertise. Not only that, you need a multidisciplinary team. So multiple people around you working for you, right? It's not just one person, just a neurologist, a movement disorder doctor. No, you need a good physical therapist, a good occupational therapist, and very important, speech therapist. And a speech therapist is not only going to work with your speech, but also with your swallowing. Okay, they are expert in designing a good exercise program to improve those muscles around or the muscles that are related with the swallowing. And also with cognition. They work with cognition as well. I'm talking about the speech pathologist. So remember what I say about medicine in 2024 is very, very complex. For example, I am a neurologist. I don't know anything about MS. I don't know anything about MS. Just to give you an idea, do you know how much training regular neurologists they have in MS? MS means multiple sclerosis, which is a totally different disease. Well, I did 2 months. So, and some lucky programs, they can have 1 month, right? Yeah, you might be exposed through the year, right? To MS patients, but specifically a MS clinic, typically you do 1 month, 2 weeks. Can you imagine? So that's why it's so important to look for expertise. Don't believe that just because you are a neurologist, you will be an expert in these conditions. And you might say, well, physicians can read and read and read, and you can learn just reading. Well, there are few things in medicine that reading and reading and read and read and read and read is not enough. You need to be trained by somebody who can guide you, especially when things are very visual. Okay, so that's my personal opinion. Now, if you want to know if your doctor is expert in movement disorder, in PSP, movement disorder, just go to the website. Usually the website will describe the background, right, and the training, and you will see, look for movement disorder fellowship. And if it's fellowship trained in movement disorder, we're okay. Now, let's talk about what type of test do you need. Let's talk a little bit about tests. If those patients require a test, any specific test? Yes. So any patient with atypical Parkinsonism, remember I told you typical is Parkinson's disease. Atypical means that it's not typical. So there's some other feature that make you think about diseases like PSP. Those patients require at least an MRI of the brain. MRI of the brain. Because sometimes you can identify, especially the Richardson syndrome, the classic PSP, atrophy, shrinking in a particular area of the brain. We call that the midbrain. Very, very classic. But remember, not all the patients will have that. Sometimes we proceed with that DAS scan. However, the sensitivity of DAS scan in PSP is not too great. It's not too high. So which means that you still can have a negative DAS scan. You can have a negative DAS scan and still have PSP. Different from Parkinson's disease. Parkinson's disease is different. We talked about that already. But in PSP, the negative predictive value, which is the probability that the test is really negative, is not as good like in Parkinson's disease or MSA Parkinsonism, which is a different disease. Okay? Now, you can, like the case that I just mentioned to you a few minutes ago, you can proceed with the skin biopsy, SIN1 test, because the SIN1 test in this type of pathology, the PSP, will be normal. Different from Parkinson's disease and MSA, multiple system atrophy, and dementia with Lewy body, that those conditions, because it's a totally different abnormal protein, they have an abnormal skin biopsy. With PSP, the skin biopsy should be normal because we are talking about a totally different pathology. I'm talking about here about tauopathy. That's the name of the abnormal protein. So this SIN1 test look for synucleinopathy, which is Parkinson's disease, Lewy body, and MSA. Now, we still don't have anything, no skin biopsy for tauopathies yet, even though that there is a paper published in 2022 that we might have at some point. But it's so difficult because there are many tauopathies. It's not as simple, and say simple, as synucleinopathy. So tauopathy is more complex. Sometimes we proceed with a PET scan, but PET scan, it might show some abnormalities in the midbrain, again, which is the upper part of the back of the head, the brainstem, but not always. Specifically, we show abnormalities in, again, the classic PSP, but not always. In other words, to summarize, MRI usually is what we get, usually. Plus, minus, could be a skin biopsy and a DAS scan, but all those patients require an MRI of the brain. Now, let's talk a little bit about prognosis. And before going to prognosis, let me tell you that remember that physicians, I'm not talking about the pathologist, physician, the Parkinson doctor, the movement disorder doctor, your neurologist, will make the clinical diagnosis of Parkinson's disease and PSP. But the provider, the person who will really make the definitive, the final diagnosis is the pathologist. So the person who will look your brain with a microscope and will see the brain grossly and with a microscope with the characteristic features, histopathology, characteristic features that you see in people with PSP. And that's the only way that you can have the correct, 100% sure the diagnosis. Otherwise, it's just based on these criteria that I showed you before, published in 2017. Now, let's talk about prognosis now. What to expect with this disease? This is the most difficult part for physicians, is to talk about prognosis. I cannot imagine being an oncologist, which is probably worse, I guess. I'm not sure, but so this is not good news at all. So this is not the same thing saying that you have Parkinson's disease. Even though that saying the word Parkinson's disease is tough, PSP is, I would say, 100 times worse than having Parkinson's disease. It's not a good diagnosis. It's not a good diagnosis. Prognosis is significantly different. Significantly different. So, for example, I have patients with Parkinson's disease that I have one guy who was diagnosed at age 27. He started having resting tremor, right hand, at age 27, and now he's almost 70. So more than 40 years. That's amazing. And still responding to levodopa very well. Why? How I know that? Because I told him I want to see him off levodopa. He could not even walk. And then I challenged him in the clinic with 300 milligrams of levodopa, and it was amazing. He improved more than 50%. So, and there are many other cases. So many cases that I have with Parkinson's disease, they had been diagnosed, they start having symptoms 15, 20, 25 years, and a few of them 30 years ago. So that's Parkinson's disease. PSP is not like that. PSP is different. And I will tell you that the median latency for onset to wheelchair bound is around 5 years. And death, so basically patients are dead, they die after 7 years. And we have the reference here. Okay. Other studies even shorter survival, especially the Richardson syndrome subtype. Remember what I told you, that there are few subtypes that they have a better prognosis by far. For example, the PSP, they might last more than 10 years easily. And also the one freezing of the gate as well, freezing of the gate. Let's take a look of this table with the prognosis, PSP prognosis, a timeline and reference. These are the reference. So if you ask me when patient with PSP, typical PSP, the Richardson syndrome, will be wheelchair bound due to falls, it's 3 to 4 years, and this is the reference. Severe swallowing problem, severe enough that they need some modification. Even a peg tooth, almost 6 years. Incontinence, which is a big deal, almost 6 years. Severe cognitive impairment, severe dementia, 6 years. And life expectancy from the symptoms of onset is around 7 years. And you see here, 5 to 8 years. And just to finalize, I prepared this table to help you to understand the difference, the clear difference between Parkinson's disease and progressive supranuclear palsy, or what we call PSP. So let's start with the walking, the gait walking. So Parkinson's disease, you can have freezing of the walking, the gait and falls, but later, after many years in the disease. And different from PSP, that happened earlier, within the first year, the first 2 years. Tremors, very common in Parkinson's disease, especially resting tremor in one hand, early sign. And PSP, very rare, except in PSP Parkinsonism, which is very difficult to differentiate from Parkinson's disease during the first 5 years. Rigidity, more pronounced in the arms, right? Arms. And in PSP, mostly the neck more than the arms. So sometimes the neck is very rigid and very stiff, and the arms are not rigid at all. Eye movement abnormalities. No issues with vertical movement abnormalities. No significant issues, no issues at all in Parkinson's disease. Except, I told you that when you get older, with and without Parkinson's disease, it doesn't matter, there is some limitation upward. That's physiologic. I'm not talking about that. Now, in PSP, they will have problems looking down. Vertical gaze is a key feature. Respond to levodopa. Good response in Parkinson's disease. So you have Parkinson's disease, you respond to levodopa. Now, watch the video about when patients don't respond. The 5 reasons why patients with Parkinson's disease tell you, doctor, this medication is not helping me. Why is that? Watch that video. In PSP, the response is poor or no response at all, even from the beginning. There are some patients that respond initially, but they cannot sustain the benefits. Cognitive changes. In Parkinson's disease, significant cognitive changes happen later and not earlier. Okay, not early. In PSP, earlier, especially with difficulty planning, multitask activities. Behavioral changes. Yes, you can have apathy and depression in Parkinson's disease, but in PSP it's more pronounced. The apathy is very pronounced and they have emotional flatness and sometimes even inappropriate behavior. Very common early on. And this is one of the things I told you about the personality that you can actually suspect diagnosis based on personality. Okay, personality. Sense of smell. So in Parkinson's disease, the majority of the patient, when you test them objectively, they will have decreased sense of smell. In PSP, should be preserved. Should be preserved. Visual hallucinations. So you don't see hallucinations in people with PSP. Very, very rare, unless it's explained by something else, right? Or you have a combined process. In Parkinson's disease, this is a late feature, late characteristic. You see visual hallucinations, very common, with and without medications. I'm talking about medication that might induce, might exacerbate hallucinations in the setting of Parkinson's disease. Autonomic dysfunction. I'm talking about blood pressure issues, right? Blood pressure, sweating, all these things that are related with autonomic system. So in Parkinson's disease, very frequent. In PSP, very unlikely, and if present, very mild, not insignificant. Unless if you have diabetes, that might actually affect by itself. You have very bad diabetes, by itself will affect the autonomic system. The progression here will be slower, significantly slower than PSP. Except PSP Parkinsonism. I told you the PSP Parkinsonism, they have a different, don't know why, but they have a different type of prognosis. In PSP, especially the Richardson syndrome, the classic one, it's pretty bad. It's very fast. It's very fast and very disabling. In Parkinson's disease, like I told you, I have cases diagnosed on more than 30 years. With initial symptoms more than 30 years, one guy more than 40 years. So it's significantly different between these two conditions. But again, it's very important that you make the correct diagnosis, either because you want to help other people in the future, because you want to be involved in research. And I actually encourage you to be involved in research, looking for, you need to help, or I suggest you to help us to find the cure for PSP and these conditions. And the only way is to be involved in research. And in order to be involved in the correct clinical trial, you need to have the diagnosis. Otherwise, many times patients get enrolled in the incorrect trial because they have the incorrect diagnosis. If you like this video, don't forget to subscribe to my channel. See you soon.